At this meeting, every year I scratch my head and say maybe quiet year for myeloma. It's not been that way, and that's a good thing for our patients. We sat through a very interesting session. When I was starting to hear about another CD38 monoclonal antibody, I said, oh my goodness, do we even need another one? We have daratumumab, isatuximab is on the verge of arriving, and now there was data which was presented by Amrita Krishnan on TAK-079, which is a new CD38 monoclonal antibody, and on its own it had a lot of efficacy with very little toxicity. And what was interesting to me was there were several patients in that small study looking at patients who had already been exposed to daratumumab, and you were still seeing responses there. So I do think we still have room in that space. There is going to be a late breaker this year's ASH meeting later on Tuesday, wherein for the first time, not for the first time, but we are using a completely IMiD-free combination in where we are using carfilzomib in combination with daratumumab, and the data looks quite good. And for the first time at this meeting, we are now starting to see 4 drug combinations in the upfront setting. That theme sort of started off with ASCO, where Cassiopeia was presented. Updated results of Cassiopeia are being presented here, and then Dr. Pete Voris is presenting the Griffin data, which is daratumumab in combination with RVD. So although that's not standard practice just as yet, the field and the landscape of myeloma is moving towards all of us using 4 drug combinations. And with this, what I think has been quite instructive to me, at least at this meeting, is people are looking at really deep responses. We're using minimal residual disease testing to assess those deep responses, in that there is a really interesting study at this meeting where it's called the MASTER protocol, where they've used KRD, so carfilzomib, lenalidomide, dexamethasone in combination with daratumumab. And what Dr. Costas has done in that small study, which right now is small and is going to be expanded, is he has actually tailored therapy based on MRD negativity. I don't think I'm saying that should be done just as yet, but at least we're doing it in the context of all of these combinations to get to the question of, if we get deep responses, can we get rid of some drugs? So that's going to be the very near future of myeloma, which to me is really the exciting part of the power of really good drugs which work together and the technology to document very deep responses. There's a few other studies which our group is presenting. We are presenting a follow-up on RBD Light, which is something which has been sort of accepted by the vast majority of people now in the space, and Dr. O'Donnell is presenting an update on the overall outcome of these patients, and we've seen really quite nice overall survival of these elderly non-transplant eligible patients in a very well-tolerated regimen. And then Dr. Andrew Yee from the MGH Cancer Center has also worked on a protocol looking at a quadruplet combination now in the relapse refractory state. So he's used pomalidomide, bortezomib, dexamethasone in combination with elotuzumab, and he has actually seen quite remarkable results in patients who've actually been refractory. This is a refractory patient population, refractory to all other treatments, generally well tolerated with a little bit of an infection signal, but in general good responses to this. So a lot of exciting things going on at this meeting. And finally, I think I will just top off by talking about bone disease, which is sort of close to my heart, and Dr. Turkpos is going to be presenting data tomorrow morning on a follow-up of our large randomized trial of denosumab versus zoledronic acid, where we had seen a progression-free survival benefit of about 10 months or so. And we couldn't quite figure out exactly why we are seeing that PFS benefit. So tomorrow we're going to be talking about why we think we're seeing that 10-month progression-free survival benefit with denosumab versus zoledronic acid.